Good afternoon. Welcome back to the HBL seminar. Today our invited speaker is Dr. Benjamin Dourthe. Dr. Benjamin Dourthe was graduated with a professional engineering degree from the National Engineering School of Metz in France in 2013. So the engineering school in France allows one to take a 5-year program after high school and get a master degree at the end of the course. And this is the program that Ben took, is that right? And in his final year at the engineering school of Metz, Ben went to the University of Lorraine and performed a study on the subject-specific musculoskeletal modeling of the human jawbone, for which he received a double master degree. In 2014, Benjamin went to University of Leuven in Belgium to pursue his PhD degree. He spent 3 years studying the osteoarthritis of the thumb joint, and will present his findings here in 3 minutes from now. After securing his PhD title in 2017, Ben flew to Calgary and joined the research group of Dr. Benno Nick as a postdoc fellow. Ben has spent a lot of time developing different skill sets throughout his academic career, which include orthopedics and sports biomechanics, signal processing, and advanced analytics. He believes that the work he has done so far can open new doors as to how we can analyze and interpret medical images, and can eventually help the clinicians in decision making for better diagnosis and treatment solutions. In the next 2 to 3 years, he plans to continue expanding his knowledge by working with experts in academia and industry in the fields of orthopedics and sport biomechanics. Ben is a travel lover. He and his partner have explored close to 50 countries on 4 continents in the past 6 years. Some of the highlights include living in the Middle East, backcountry camping on the Great Wall of China, crossing the Siberia on the mythical Trans-Siberian Railway, and many more. And I'm glad that he makes a stop at Calgary to deliver his seminar right now. Let's welcome Ben with the title of his talk, Osteoarthritis of the Thumb Joint, Occurrence, Mechanisms, and Understanding via Computer Modeling and Medical Imaging Techniques. Please.
Thank you very much for the introduction. So, what is osteoarthritis of the thumb? Let's start with a quick definition to tell you what exactly osteoarthritis is. So, osteoarthritis is a degenerative joint disease which is characterized by a progressive loss of cartilage. In terms of symptoms, it translates usually with some articular pain, and as soon as the disease progresses, you can easily lose your ability to move your joint, and it leads to a loss of joint function. Now, who is mostly affected by osteoarthritis? If you look in the literature, and specifically on thumb osteoarthritis, we know that it mostly affects women, and it's also strongly associated with aging. We also know that osteoarthritis affects millions of people worldwide, making it a leading cause of disability. Now, what about its development? As you can see here, there are many factors involved in osteoarthritis development. It can be genetic inheritance, hormonal variations, excessive joint loading, ligament laxity, and the list goes on. All that to show how complicated this disease is and how multifactorial it is. And also it's important to know that we still don't fully understand how it works. Now the next question is, why are we focusing our work on the thumb joint? So let me ask you a quick question. What would you do if you're unable to use your thumb? So let me give you a few examples of activities of daily living that we all do that require the use of our thumb. So now just look at these images and take a second and think, what would I do if I was unable to use my thumb to hold a pen and write something? What would I do if I was trying to hold an object or open a bottle or a jar? Or what would I do if I wanted to navigate on my phone if I was not able to use my thumb? That sounds pretty complicated. On top of that, it's important to know that the thumb has barely been studied in the literature, meaning we don't fully understand how it works as well. So in summary, here is our research problem. On one side, we have a disease, osteoarthritis, which we know is strongly affecting our population, can be very disabling, and yet we don't fully understand what causes it. On the other hand, we have our thumb, which we extensively use and it's underestimated in the literature, so we don't fully know how it behaves. So all that clearly shows that there is a real need for further research in that specific area, so that we can better understand how osteoarthritis behaves and occurs and how our thumb functions. So that was the objective of my research project. So here are the list of my different objectives, and the first one was to try and design new tools that would allow us to measure thumb function. Then using these tools, I was hopefully to find biomechanical correlation between thumb function and osteoarthritis development. And then my ultimate goal was to try to use all the insights from these different tools and analysis to try to improve the current prevention and treatment strategies for this highly disabling disease. So let's focus on our first objective for now, which was to design new tools to measure thumb function. And of course, when I say thumb function, it can be interpreted in very different ways. So in the context of my research, I decided to look at it with two separate angles, the first one being thumb kinematics, and the second one being joint contact. So let's focus first on thumb kinematics. So here we designed a study which objective was to assess how osteoarthritis impacts the mobility of our thumb. So now how do we measure thumb kinematics? And I'm sure being in this environment, everybody here associate kinematics with the use of motion capture, which makes sense if you want to study the mobility of locked joints, like the knee for instance. But when you work with the thumb, things are very different because it's a very small joint, meaning that using a motion capture is not possible because it wouldn't be sufficiently accurate to quantify thumb kinematics. So we needed an alternative, and what we decided to go for was to use an approach based on medical imaging. And here is how it works. So in the first step, we start by collecting medical images of the hand while performing different motions. So for that we use a CT scanner, which will basically take a scan, which are a combination of different two-dimensional slices of your bones. And we're going to do it at the beginning and at the end of different tasks. So here we decided to focus on two basic thumb motions. So we position the hand of our subjects in a standardized rig, which will guide them through the standardized motion. And then we simply took a scan at the beginning and at the end of this task. Once we had these scans, the next step is to reconstruct the images. So we take all our two-dimensional slices provided by our CT scan, and we put these two-dimensional images together to create a 3D model of the hand. And once we have that, the last step is to calculate the corresponding kinematics. And the way that works is that we're going to isolate the kinematics chain of the thumb, and we're going to simply register our bones from one position to the next using anatomical landmarks. So we manually select the same anatomical landmarks of the bone in position 1 and position 2, and then use these landmarks to calculate the corresponding transformation matrices, which will tell us how the kinematics of the thumb is. And in the context of that research project, we decided to focus on two specific bones, being the MC1 over here, and also the trapezium over here. So these are our two bones of interest. Now in terms of protocol, we had two separate groups. First, we started by collecting CT scans and measuring the kinematics of 16 healthy controls. And then we had a second group of clinical patients, so 4 of them who had advanced osteoarthritis. And we started by measuring their kinematics, and then they underwent a clinical intervention where their thumb was replaced by a prosthesis. And then following on a 6-month recovery period, we measured the kinematics again. So here the objective was simple. We first wanted to be able to assess what the healthy thumb kinematics look like, and then see how osteoarthritis and total thumb replacement will affect that kinematics. So let's look at our results and focus first on our healthy group. So here you can see 2 tables that summarize our results. So it basically shows the different rotation angles that were calculated for our 2 bones of interest, so the MC1 and trapezium, during our 2 thumb motions, being thumb adduction and thumb flexion. So here you have the 3-dimensional rotation angles, and what we can see here is that even though the tasks that we were studying were supposed to be more or less planar, we still observed rotation angles in 3 dimensions. And on top of that, in the literature, most research labs have for now studied the mobility of the MC1. Nobody had ever studied the mobility of the trapezium, and we can see here that even though we perform basic thumb motions, the trapezium has non-negligible rotation angles as well. So what we can conclude here is that when you look at healthy thumb kinematics, the thumb motion is multidimensional. And on top of that, it's important to understand that the thumb functions as a multi-dimensional joint as well. So you cannot look at the thumb mobility by only looking at one joint. You need to look also at the mobility of the bones located in the wrist, like the trapezium. Now let's look at the impact of osteoarthritis. And first, let's look at the impact that it has on the morphological level. So here you can see two reconstructions for the MC1 and the trapezium, which will show you the differences in morphology between a healthy thumb and one that has been affected by advanced osteoarthritis. And as you can see, the morphological changes are pretty significant, to the point where even the direction of curvature has been changed for some of the bones. And as you can expect, this will have an impact on the mobility. And it was true, because if you now look at this table, which is almost the same than the previous one, but this time we decided to focus on one specific rotation angle, which was the ab and abduction rotation angle, because it's the one that was the mostly affected by osteoarthritis. You can see that the mobility of the MC1 has significantly been decreased during both motions. Now if you look at the mobility not of the MC1 but of the trapezium, it's the opposite. You see that the rotation angles have increased as a result of osteoarthritis. And that's very interesting, because what it shows is that osteoarthritis affected our thumb morphology, which had an impact on the mobility of our thumb. And what we observed here is that when the mobility of one bone is affected, there are some compensatory mechanisms that occur, which are there to kind of help the thumb to recover its full range of motion. So again, the bones located in the wrist are important to look at when looking at the mobility of our thumb. Now let's look at our final comparison and look at the impact that replacing our thumb with a prosthesis had on our mobility. So again, I'm focusing on our ab and abduction angle here, and you can see that in both cases the mobility was not fully restored. So if you look at thumb adduction, the mobility was decreased compared with our OA group, and if you look at thumb flexion, it was slightly improved, but still not quite as much as our healthy group. So what we can conclude here is that current implant designs are not sufficient to fully restore our healthy thumb kinematics. So to conclude on that thumb kinematic study, what we observed was first that the thumb behaves as a multidimensional joint, that it functions as a kinematics chain, and that we observe these compensatory mechanisms that are very interesting. And finally, we saw that current implant designs are not fully able to restore our thumb mobility. So that was the first tool that was designed in the context of that research project, which we used to measure one aspect of thumb function, being thumb kinematics. Now let's focus on the second aspect of joint function that we decided to look at, which is joint contact. So here we have another study, which objective was simply to assess how the pressure is distributed inside your joint in vivo, meaning that we want to see how the pressure is distributed on living subjects. And so the first question is, how do we measure joint pressure in vivo? Because if you want to measure pressure, you usually use sensors, right? But here the problem is that you cannot use sensors, because if you expect to ask your living subject if you can open up their thumbs and put a sensor in it, that's not going to be possible. So we need another approach. So the approach that we decided to go for was to use computer modeling. And here is how our model was designed. In the first step, and following the same idea that we have for our kinematic study, we start by collecting medical images. So we use our CT scan again, and we collect CT scans of the hand in different positions. So here we have 8 positions. The first 4 ones are basically the same than for our kinematic study. And then we added 3 isometric tasks, which are all representative of some activities of daily living. So we have lateral pinch, power grasp, and jaw twist. And finally, we had just a neutral configuration to have some form of baseline. Once we have that, second step is again the same. We just reconstruct our images, and we're going to focus again on our 2 bones of interest, being the MC1 and the trapezium. And then the last step is to calculate the distribution of joint pressure using a cartilage model. So the way that works is that we simply generate an artificial layer around the articular surfaces of our 2 bones, and then we simply measure the distance between our 2 bones, and it will help us to identify a zone of contact where there's an overlap between our cartilage layers, from which we can calculate the corresponding cartilage deformation, And knowing the deformation, we can use a mathematical model to calculate the corresponding pressure and generate the corresponding pressure distribution maps. So that's the way our model was designed. Now here's the protocol that we used. So we started by collecting CT scans of 20 healthy controls, and we measured their joint pressure in the 8 different positions that I showed you before. Now let's look at our results. And first, let's start by comparing our subjects to see what the variability was like. And here what we can see is that there is a very low variability between our subjects. So what it means is that if you ask a person to perform a specific task and if you ask a different person to do the same task, we observe the same kind of contact patterns. And here you have an example with 6 different subjects performing the same task, which was thumb abduction. And as you can see, the contact pressure is always located within the same area of the thumb. Now if we look at the variability between tasks, it's a different story. So here are a few examples of the kind of contact patterns we observed for 6 different tasks. And as you can see here, every single contact pattern is very different from one another. Now that being said, what we observed, even though these patterns are all very different, we also have one zone of recurrent peak pressure that is located here, located in these white circles, which shows that there's a recurrent zone of peak pressure within the different tasks that were performed. And that's also a very interesting result, because if we now go back to this image, where you can see the difference in morphology between a healthy thumb and one that has been significantly affected by osteoarthritis, and if I now highlight the zone that was identified as being under constant peak pressure, according to our data, it corresponds to the zone of the thumb that has underwent the most significant morphological changes. So according to that study, what we tried to do here was to design a new non-invasive approach that allows us to assess articular pressure in vivo. And based on that model, we were able to detect some signs that there is an association between how the contact patterns are distributed and where osteoarthritis is going to occur. So now that this has been shown, it's important to note that we have some limitations to the different approaches that we defined here. So here are the 2 major ones, starting with radiation exposure, because as some of you may know, when you use a CT scanner, it's based on ionizing radiations, which means that in this kind of study, for each task that you want to study, you require 1 CT scan, which means that if you want to study a lot of tasks, you're going to expose your subject to a large quantity of ionizing radiations. So that's something we would like to work on. And then the second important limitation of that approach is that we used a generic cartilage model. So basically we had a model of the cartilage that was constant throughout our population. So the cartilage had similar properties, similar morphology, which as we know is not representative of what happens in real life, because we're all different, we all have different thumbs with different morphology and the cartilage with different properties. So these are the 2 limitations we will try to approach in the next part of this presentation, starting with the first one about radiation exposure. So here the question was, can we design a new approach that would require less scanning? And for that we decided to look into forward modeling. But first of all, what is forward modeling? So in biomechanics there are 2 very opposite approaches, which we call forward and inverse modeling. And the best way to understand the differences between these 2 approaches is to look at it this way. So forward modeling is mainly about predicting what's going to happen, and inverse modeling is about observing what happened. So to give you some more concrete examples, here is a summary of what was done until now. So we basically collected a lot of series of CT scans from which we observed how the pressure was distributed. So that's an example of an inverse modeling approach. Now what we want to do next is to get rid of most of the scans and just focus on one, from which we're able to extract the morphology of a subject and then use computer modeling to perform task simulation. So that's an example of what a forward modeling approach is. So now let's look at how our forward model of the thumb was designed. In step 1, always and forever, we start with a medical imaging approach. So we start by collecting a CT scan of the hand, from which we'll extract the morphology of our hand, and then focus again on our 2 bones of interest, being the MC1 and the trapezium. Then in step 2, we try to model the passive anatomical structures. So we are going to model the cartilage and the ligaments around this joint and implement their behavior using a computer model. And then the last step is to perform different simulations. And the way we're doing it is by applying an external loading on the thumb, and then we're going to be able to simulate different tasks using this loading. So in summary, here is how a model behaves. So once we have defined our model, we start by loading it, and based on the property of our loading, we will be able to initiate motion. And that motion will initiate some reactions in the ligaments and cartilage. So the ligaments will be stretched, the cartilage will be compressed, all that leads to some form of reaction forces, which will progressively oppose to our original loading, up to the point where we can eventually reach equilibrium, and from which we can perform our original analysis on the distribution of joint pressure. So that was the idea. Now, after designing that model, we needed to test it to see whether or not it was functioning. And when you have a complicated model, you need a simple example to try to test it. So what we did was that our objective was very simple. We just wanted to try and simulate thumb flexion. So for that, we just apply one load at the top of the MC1, going vertically to try to make it go down and perform flexion movement. So the loading characteristic was very simple. It was just one force, one direction, one point of application, and we tried it with a series of different magnitudes. So now let's look at the results. So if you first look at what happened when we didn't load the thumb, equilibrium was reached with almost no motion, which is what you would expect. If you don't load your thumb, you don't expect it to move. So it was a positive sign that our model was correctly implemented. But then when we started to load the thumb, it was a different story. And what we observed here was that we were not able to reach equilibrium when we started to load the thumb, which means that either our implementation was incorrect or the anatomical structures that were modeled were not sufficient. So in conclusion here, what we did was, and it's important to note that at this stage, no forward model of the thumb had ever been designed. So it was the first attempt to try and design a load-driven computer model of the thumb. So we started from scratch, and I think we still did a significant progress in that direction. And thanks to that study, we were able to tell that the passive anatomical structures that we decided to focus on did not suffice to produce stable thumb kinematics. So there's still more work to do in this direction. So now let's go back to our limitations. Here we try to address the first one about radiation exposure, and as we can see, there is still more work to do. But for now, we're going to focus on the next limitation, which was about the fact that we used a generic cartilage model in our different approaches. So now the next step is, how can we build a model that would be subject-specific for the cartilage? And for that, we need to look into cartilage properties. So here we designed another study which objective was to find a way to assess the cartilage properties in a non-invasive way. Because as you know, if you want to assess the properties of a material, it's always invasive, and if you want to work with biomechanical structures, it's usually cadaveric work, meaning that in that case, it wouldn't be applicable in vivo. But we wanted to find a way to go from cadaveric to in vivo, so that was the objective of that study. And here is how it was designed. In the first step, we start by collecting cadaveric thumbs. So we had 16 cadaveric thumb joints, from which we performed indentation testing, which allows us to calculate the corresponding mechanical properties of the cartilage of the thumb. Once we have that, the next step is to use a new technique called contrast-enhanced CT. So we basically use a high-resolution CT scanner, which has the advantage compared with a regular CT scanner that we can actually visualize the cartilage on the medical images, which was not the case before. So thanks to that, we can visualize the cartilage and extract its morphology. And then the second step is to use a contrast agent, which we know will react with one component of the cartilage called glycosaminoglycan. And in the literature, it's been shown that the content in glycosaminoglycan in the cartilage is an early indicator of osteoarthritis when its content decreases. And it's also an indicator of cartilage stiffness. So in summary, thanks to that method, we can on one hand know the morphology of the cartilage, and then using this contrast agent, know its composition. So then the last step is to put all the pieces of the puzzles together. So on one side, we have the mechanical properties of the cartilage. On the other hand, we have the composition. So based on that, we want to be able to predict what the mechanical properties will be as a function of its composition. And here are our results. So on this graph, you can see the correlation between the mechanical properties of our cartilage samples and the corresponding content of glycosaminoglycan, which is reflected by the image attenuation from the CT scanner. And here you can see that there's a clear positive correlation between the mechanical properties of the cartilage and its composition, which is what we wanted, because then using this kind of data set, let's say tomorrow you have a subject coming to your lab and you want to perform some analysis on him, you can just perform this technique and use medical imaging to know the morphology of his cartilage, of his bones, and also know the mechanical properties of his cartilage that you can then inject in your model. So in summary here, what we tried to do was to design a non-invasive approach to try and assess the properties of the cartilage. From that design, we were able to detect that there was a positive correlation between the cartilage properties and the content of glycosaminoglycan, so we can now correlate the composition with the mechanical properties. And ultimately, this kind of methodology will allow us to develop subject-specific cartilage models, which will enhance our accuracy when we predict the behavior of the thumb. So to conclude that presentation, let's go back to what our original objectives were and see how we performed. So the first objective was to design new tools to try and measure thumb function. And I think we were pretty close, because what we did basically was to use the most modern medical imaging techniques and from them design algorithms and models that allow us to measure thumb kinematics and also the distribution of joint contact. Thanks to these tools, we were able to detect some form of biomechanical correlation between thumb function and osteoarthritis development. Because if you look at our thumb kinematic study, we saw that osteoarthritis impacted thumb function by impacting its morphology and having an impact on its mobility and linking to these compensatory mechanisms that were observed. So OA does impact thumb function. And on the other hand, we also observed that thumb function has a link with osteoarthritis development. Because what we saw here with our joint contact study was that if you know where the peak pressure is going to be located, you can almost predict where the most significant morphological changes will occur. And of course, I tried to be transparent about the different limitations of these different projects, and we tried to address them as best as we could by designing this forward model, which, as I tried to show, is still not fully functioning, but at least it's been a significant progress in the field, and I think it's still the right direction to go with. And then with our cartilage property and these new models that now allow us to improve the accuracy of our model by making them more subject-specific. So in conclusion, I believe that all the framework that was developed in this project helped us to answer our ultimate objectives, which was to improve the prevention and treatment strategies of osteoarthritis. Because what we tried to do was to basically design a biomechanical toolbox that we can then use in a clinical context and help our clinicians to improve their clinical interpretation. So all that together, we now have new tools that can help us to better understand how osteoarthritis developed and how our thumb functions, and be able to better understand and prevent this very disabling disease and improve the current treatment strategies. So to conclude that presentation, I'd like to have a few acknowledgements. First, for my supervisory committee and my colleagues from the University of Leuven in Belgium, and also to my mentors at the University of Southern California and the University of British Columbia, without which this whole framework wouldn't have been possible. And of course, I'd like to thank you all for your attention and for being here today.
Ben, with the forward modeling, what was the source of some of the errors that caused that instability in the system? What were those errors, and do you think you have a source for them?
So what happened with our forward model is that when you start loading it, it will initiate the motion, as I explained, and then what happened is that we had basically torques happening in all directions, and two of them were able to reach equilibrium, but one of them kept increasing, so the thumb kept moving and moving up to the point where it became unstable and nothing was predictable anymore. So my understanding is that this problem can be multifactorial. There are many reasons to explain it. The implementation might be because it's a very complicated problem to try to solve. There's a lot of equations behind it, so there could be errors in there, but also in terms of just purely anatomically speaking, what we had is that we focused on the ligaments that were defined in the literature to be the most important ones of the thumb, which were basically all like on top and bottom of the joint. But the torque that we had was in the other direction, which means that there is nothing to try to compensate that torque from increasing. So I think the problem is multifactorial, as I said, and the implementation can be improved, but also in terms of pure anatomical design, it's also not fully functional and would still requires more work to be improved.
And did you have passive forces from like the muscles in that thumb, or did you?
No, well, the idea was that the loading that we apply, so for now it's just a simple vector, but the idea ultimately, once we have a functional system, was to use these forces to replace muscle action, so that ultimately we can define different muscular forces that will allow us to control the motion. So the muscle forces are what you try to apply to the system, so they do not directly impact on the reaction of the structures.
I have one question. I'll ask a question first. So my question is, what is the typical thickness of cartilage in the healthy and OA patients in the thumb joints, say between the MC1 and the trapezium?
Sorry, can you repeat your question? I didn't hear you.
Typical thickness of the cartilage.
Thickness? So it's usually less than a millimeter for the MC1 and the trapezium.
So what is the range?
So it's usually around 0.7 millimeter, and for one bone, I think for the MC1, and 0.8 for the trapezium.
So if there's an OA, is there an increase in thickness?
No, it decreases. Basically, OA is going to like progressively degenerate the cartilage, so it's going to decrease in thickness, and in some areas you will have no more cartilage existing. And this is when usually the bone-to-bone contact starts to occur, and this is when you start feeling pain, and when you have these also morphological changes occurring as a result of bone remodeling due to this high pressure occurring within the joint.
So yeah, so all the OA patients that we are looking into, they are end stage OA.
They're in the latest stage, so we have like 4 different stages on a specific scale that is defined in the literature, and those are all stage at least 3. So pretty late. Usually these people are like scheduled for surgical intervention, and that was the group that we also went through our surgical intervention for our kinematics study.
I'll let Dave go first because don't want to steal all the good questions. I know what he's going to.
So if most of the people who have thumb OA are females, in your assessment, either using CT in the contact area, etc., A, you find any differences between males and females, and B, if it's aging, are there changes that occur in postmenopausal females versus younger people?
Yeah, so for these studies we only focused on women because of that statement, because we really wanted to have the population that is the most affected. So we had healthy females and OA females. So we didn't have, like, these tools were not applied on males. But to answer your other question, in the literature it's shown that it mostly affects women after the menopause. So it's why, like, when I try to show the different development factors, there was also some genetic and hormonal variations that impact OA. Because in the female population after the menopause, the occurrence of osteoarthritis increases very fast. So we know that it's mostly affecting women also because of that reason.
And when you talk to some people doing some tests as they get older, like twisting a top off of a can or a bottle, seems to be much more effective than being able to grip something. And so are there some predisposing changes that occur with the aging of the hand, that, like, development of sarcopenia or weakness in muscles, specific muscles, that can be attributed to the onset?
That's possible. I think also for different tasks we use like different muscular strategy. So when you grasp, or when you, like, for this kind of task where you can use also the muscle impact of your other fingers, you can try to always compensate. So if one joint becomes like more unstable or weaker, then you can use others. Here we try to really assess different tasks, so we have pinch, grasp, and jaw twist. We didn't really look at the difference in like muscle forces. That was not really our focus, but I imagine that when you age, it either becomes weaker or then the strategies become different in the way you use your thumb to be. I think the body is always adapting to your environment, and what you try to do is always be able to reach your objective. So if you want to perform a task and if you have one joint that becomes weaker, then all the muscles and all the joints will try to compensate.
I thought you might ask the sex question, so I'll ask a technical question. And the first would be the dynamic range of your contrast imaging in CT versus the degenerate, for example, in MR. In this case, your contrast agent is a positive contrast agent. It binds to the proteoglycan negative charge. And so I'm just curious if you could comment on that, as I say, as compared to the degenerate, which is a negative contrast imaging.
So here what we tried to do was to use a method that was still fairly new, like this contrast agent has not extensively been used for now. And it was all about, here I tried to define a correlation. I presented it this way, but the idea was also to see whether or not the content of glycosaminoglycan was correlated with the mechanical properties, which means that if the content is higher, do we have a higher Young's modulus? And that's also what we had. So that study was also to help us identify these two things, because this is still a research area. Ultimately, it would be good to be able to use that method to extract the mechanical properties. That's the ultimate goal. But for now, it's still under research to be sure that if we know the content in glycosaminoglycan, we can extract the corresponding mechanical properties.
My second question was about the pixel size, voxel size of the CT. You have these beautiful images, surface images, and obviously it's a small joint. And I just wonder if you might care to comment on the resolution you use, and the resolution you think would be important to use in these sorts of studies.
Yeah, I think this is a very good point, because the resolution does have an impact, especially if you look at our joint contact model, because it's based on the distance between the bones. So the higher your resolution will be, the most accurate it will be to represent the actual geometry of your bone. And so if you have a lower resolution, you might have errors in the distance that you calculate. So the regular CT has a resolution of about, I think, 320 micrometers, which is pretty high, I would say. And then now we're working with these other techniques. So the high resolution CT has a resolution that goes down to 40 micrometers, and that can be used in vivo. I think for now we use the 82 micrometers in vivo, but we can go down to 40, which is close to the resolution of a micro CT on this large scale. So it's getting better, but in the context of that project, we did with what we have. And I think that the next step would be to also use this high-resolution CT scanner to perform the same analysis and see whether or not the results have been significantly changed or not.
I'm just wondering if you model it as solid phase or biphasic, if you have fluid and solid phase, and if you study the effect of osteoarthritis on the water content.
Sorry, can you speak a little louder? I couldn't hear you.
Do you model it as a monophasic material, solid phase, or is it usually modeled as a fluid and solid?
For the cartilage?
Yes.
So I use the biphasic model to model the behavior. So
with osteoarthritis, do you notice that the water content would increase or change, and would that be reflected in your model? Because that would change the pressure values and so on.
So I didn't look at it this way. I used the model and I had constant properties, so I couldn't really assess the differences in water content. All that was kept constant at this stage, so I cannot really answer that.
Thanks.
This is kind of related to that question. What does the cartilage modeling give you that proximity mapping for?
I can show that. So that's the model that I used.
So, but if you calculate the stress then and you show me a proximity map and then you show me what the stress is, they're going to look nearly identical, right?
That's correct, and that's how the model was originally designed. So we started with a proximity model, just based on distance. We had the same form of heat maps, and we used that approach to be able to compare our healthy group with our OA group. Because the problem here when you start to implement this cartilage model is that it's not applicable to a population that has OA, because they basically lose their cartilage, so you cannot make any assumption on that. So we first had a proximity model that we used to compare our two groups, and then we tried to improve it by using this function to calculate the stress. But as you said, it's pretty linear, so meaning that the results are very similar when you look at it this way. So then we try to look at other models of the cartilage which are more recent and more developed, but then they go really deep into the molecular structure of the cartilage, and it makes the model very complicated and sometimes with not much gain. Because if you go back to the previous question about the resolution, I think the error we would have on our segmentation error would be already bigger than the kind of error you would have by improving the cartilage model. So I think it's a step-by-step process, and there's definitely more work needed to improve the modeling of the cartilage, but it's a slow progress. So I agree that we should have a different model, and it's probably the next step.
I'm not convinced that you need a different model. I mean, that was going to be my next question was, is joint congruency the main determinant of the contact pressure distribution? I mean, I guess you could fuss with the material properties of the cartilage model all you want. You could do a sensitivity analysis, right, and see
Yes.
if it really impacts the stress itself. And I'm just wondering, what's more important, the cartilage model or the accurate STL models that you get?
Yeah, for that project, we really focused on the congruence, as you said, and also in the literature, that's what's been done mostly at this stage. So in order to be able to compare our work, we focused on that aspect first. So then my idea was to try to change the cartilage model to go a little deeper into the accuracy of it. But then there's all these layers about the segmentation accuracy that you have to cross first, and then improve your cartilage model and do this sensitivity analysis to see whether or not it does change. I'm not convinced it will, but I think it would have been an interesting project, but I didn't have time to go through that in the context of that work. But I think that would still be an interesting thing to look at. But I think I still agree with you that for now, congruence is the determinant factor in how the stress is distributed in the joint.
I have another question. I really like your idea of trying to use the mechanical indentations approach and then match it with the in vivo imagings, using the contrast agents that you use for the gag content.
Yes.
But then can you pull out the results again? Yeah, so if you look at one specific joint, it does shows very pretty linear relationship.
Yes.
But if you take cartilage as a general things, and then you look at the data as a whole, there just seems to be no trend. What's your thought about that? You know what I mean?
Yes, but I think, so you're basically saying that here you cannot have just one single model that will define the behavior of cartilage in general, using the medical images.
Correlate the image intonation of the HU unit with the mechanical stiffness, right? In young modulus, for represent cartilage. But then your trapezium cartilage, MC1 cartilage, and the other one, only these two, they match quite well, but not these two. So what happened to this one?
So what happens here is that these two curves here, so the blue and gray one, represent the results we had for the full depths of the cartilage. So it's still these two bones, MC1 and trapezium, which match pretty well. And same thing for the other one, so the yellow and orange one are for the still MC1 and trapezium, but for the superficial depths of the cartilage. So the difference here is that, if I can show you another image to explain that. Oops. So here you have the corresponding CT image that we got and the corresponding image attenuation. And on the middle and right, you can see the difference between the segmentation of the full cartilage and the superficial cartilage. And the reason why we isolated these two was because the indentation testing is done on the superficial cartilage, because you go through like 10% of the thickness of the cartilage when you use your indenter. So the results that you have most likely represent the properties of your superficial cartilage. So then the correlation makes more sense then, but we still wanted to see if it reflects for the full cartilage. So if you look at these two separately, it looks like there's no correlation, but now if you think about it as two different layers of cartilage, then it makes sense because the composition might be different if you take just the superficial layer of your cartilage or the entire cartilage as a whole. So then if you use, actually if you would want to use that kind of approach for your modeling technique, you would probably just stick to one of them. And if you stick to one of them, then you see a trend. That is the same for the two bones. But since the composition varies between the layers of cartilage, then that makes sense that we have different results here.
Because the composition changes with the layer, I would expect that the attenuation value would correspond to a different Young's modulus value. And so, yeah, I kind of have the same question about this figure here. So I'm just wondering, is it that when you illustrate the Young's modulus measurements for the full depth cartilage, that measurement isn't very meaningful because it's really just reflecting the modulus of the superficial cartilage?
It would be less meaningful, I imagine, because like I said, yes, the indentation really reflects the properties on the superficial layer, but we don't really have a way to do the same test like layer per layer. So ultimately, we would use probably the model for either the superficial or the full, depends on what we decide to do. But I think it's more reflective when you think about the superficial layer because of how the indentation test was performed.
I have another question. Can you show the stress distributions in your modeling project on various types of adductions, neutral positions, pitch, the stress distributions on the is it right?
Yeah, I didn't show them there because it would be a lot of information, but they're usually mirrored from the MC1 to the trapezium because they're facing each other. So if you model like these two surfaces like that, if this is your MC1, this is your trapezium, let's say this is what you do during abduction and adduction, then you would have like facing zone of peak pressure.
Okay. Do you mind to pull out that slide?
The slide I had for the MC1?
Yeah. So my question is
this one?
yes. So my question is that is this color scale all the same for one scale bar?
Yeah, it's based on the mechanical properties. So we have a specific value depending on the value of the aggregate modulus, and this is what defines the color scale. So they all are on the same scale.
So when you pitch, it's the stress is the same as when the thumb is in the neutral positions.
Yes, I mean it's
how hard you pinch actually?
it's a sub-maximal force, so it's just 80% of your max.
80%. So is it convincing that when you pinch you exert no stress on the upper joint?
So the scale, the way it's defined is that it goes from 0 up to the aggregate modulus, which is the value up to which we expect to have damage. So after that value, everything becomes red. So you don't have any more transition. So you know that when it's red, it's potentially damageable for the cartilage, but there's no more transition. So that doesn't mean that the red that you see here or here is exactly the same. You just know it's above a certain threshold that would potentially damage the cartilage, but you don't know exactly which one is the highest. So we still have these values in the corresponding paper. Here is just like the visual. We also have the different values for the max stress that was calculated for each task, and we saw that, of course, it was not the same. So there was tasks, especially for the grasp, where you can use actually the most strength. That's where the pressure was the highest in the thumb.
I have one last question. So before this talk, we know very little about thumb joint, right? Except for the study that you're obviously that you do perform maximum contractions on the thumb and then you measure the forces of the muscles.
Yeah.
And you know what is if isometric contraction, the forces that exert on the thumb joint is damaging, or what is the level of the force that is damaging the joints, then you should not do it. You should avoid it.
Well, I wish I could answer that question, but the point being that what we've observed is that in some cases, like excessive mechanical loading can lead to osteoarthritis and cartilage degeneration, but it's not always the case. It's not like a linear problem where I can tell you, like, if you use this amount of force, you're gonna injure yourself. Because some people react differently, because there's other very complex mechanisms involved. So it's not very a linear problem. In this project, we try to look at it with a mechanical perspective, but I'm still aware that osteoarthritis is multifactorial, so there's also like genetic problems and a lot of other factors that can lead there. So I cannot answer this question even though I wish, but I'd say just still be careful with your thumb, of course.
Okay. Yeah. No statement. Friends.
I get the last question.
Yeah.
I just thought I don't really know the answer to this. Maybe you do. How successful are thumb joint replacement surgeries?
It's not 100%. So like I try to show here, like people can use their thumb after you do a total thumb replacement. Most of them take it well, like there's no rejection or anything, but in terms of like recovery for thumb mobility, it's not always perfect. Like they can still do things, but not as great. And we've observed like some of our patients, they had a thumb replacement, and if they are like, for instance, like working in a factory and they use their thumb extensively, the prosthesis lasts like 2-3 years, and then they have to replace it again. And that's not great at this point. And the problem with this kind of techniques is that you don't yet have a solution that is like for long term. So even though if you're like pretty old and you don't do much with your hands and thumb, it's going to last maybe 10-15 years, but then you still have to replace it, and each time you want to replace it, you have to take more of the original bone, just like we do for the knee. But these bones are very tiny, so there's not many options to like keep replacing your prosthesis. So for now, they still do it when it goes as badly as the images I showed, where the morphology is really bad. They also tried other techniques where they just simply remove the wrist bones and try to create a new joint with your radius, for instance. There are different approaches, not all of them are as successful, and again, people react differently, so it's always based on the surgeon and how the patient will react to the solution that is proposed.
Well, Dave would claim the last question.
The last question. So is thumb OA more prevalent in the dominant hand?
Yeah, for that study, we also focused on the dominant hand because I think according to the literature, it's mostly dominant there. But again, like we still observe some people where it's the opposite, so it still varies a lot from people to people. So it's hard to predict. But the general trend seems to show that it is.
When you did your assessments like this one, are there any differences between dominant and non-dominant hand?
We didn't look at that, so we didn't compare between left and right hand. We focused on the dominant hand of our subjects. So I cannot know for sure.
All right, let's thank Ben again. Next week, our invited speaker will be Olivia Bruce, who's sitting back there, from Dr. Brent Edwards' lab, to present findings on the real-time monitoring of Achilles tendon strain in basketball players. See you next week.